Hey Sharon, before we start, is there a list of the presenters? I just don't see it on the page in front of me. I'm sure there's another email I have with a list. Or is there someone who will queue them to let me know who goes next?
So yes, there is a list. It's right here. It should have been in that first email
Okay,
that I sent out, but I will jump to this page after each presenter so you can see who's next to call the next person.
great. Thank you.
You're welcome. Good afternoon, everyone. We will get started here in just another minute or two. If you are a committee member, if you would put your name in the chat so we can capture that for the meeting minutes. If you are a committee member who is on the phone calling in and can't use the chat, if you would unmute and let us know that you are here, we would appreciate that. Again, we will just get started here in just a few minutes. We are waiting for a quorum. Okay, for those that just joined, we will be getting started here in just another moment. If you are a committee member, if you would put your name in the chat. If you are a committee member who is on the phone, if you would unmute and let us know that you are here. We don't yet quite have a quorum, Dr. Britton, so just trying to give it another minute. Do we have any committee members who are on the phone today? Okay, so Dr. Brighton, if you just want to kick us off, we will just have to skip the meeting minutes because we do not have a quorum. Thank you.
All right, well, welcome to the May meeting. It's an exciting one where we get to hear from our community partners. Since we're holding up on the minutes, our first topic is to thank Stephanie Burdick for her service to the MAC and her service to the greater community in Utah as well. She's been an amazing advocate. So if we can give her our thanks, and she's really irreplaceable. I see that someone has raised a hand. Stephanie, you have been so appreciated and you'll be so missed, and we hope to still continue to work with you to advocate for our families and people throughout Utah. We are also accepting nominations for consumer representative, and you can reach out to Sharon for more information if you have someone to nominate or if you'd like to nominate yourselves, those who are not yet members of the committee. All right. So do we have a question, or is that a clap? I know sometimes I raise my hand when I'm trying to clap. Any questions out there? Okay, we'll move on then. Dr. Jennifer Sorhecker will discuss with us now the overview of the budget recommendation process. We'll turn the time over to her.
Hi, thank you, everyone. We appreciate you joining us today for this very important once-a-year meeting. We all look forward to the opportunity to hear from you. So just to appreciate the role of this meeting today in the context of the whole budgeting process. First of all, you know, as we wrap up the legislative fiscal year for this year and then look towards next year, this is really one of the first steps that we have to kick off our budget consideration process. And as the department has the opportunity and the Medicaid agency has the opportunity to put forth funding requests to be considered within the governor's budget, the MAC plays a critical role in being able to put forth requests in this setting for the department to consider. And so in this environment, we will be able to hear your requests individually. And then, of course, the MAC committee will rank those at the end of this process. In the next meeting, there will be a vote. And at that point, they are then given to the department, where we are able then, within our program, able to look through the different requests and look at their ranking, and then be able to consider those for input into the governor's request. There's no guarantee, of course, that our requests will be picked up by the governor's office to receive funding, but it's an important process for you all to give input and share your voice about how we can better serve Medicaid members through your submissions. It's really important. You're in the community and you're working, many of you are providers or perhaps caregivers or even individuals who recognize policy and have found areas where we could strengthen our work. And I think this is the opportunity for us to hear about those ideas. We appreciate you coming to the meeting today, taking your time. We know it's a 2-hour meeting, so it's a long haul. And so we appreciate that you've taken the time to create your request, that you've practiced your presentations, and then we will be attentive to what you're putting forth today. So we thank you for this. We will not be able to know exactly what the outcome of this particular request is until the governor does publish his budget priorities. And that does not happen until usually November. So it's kind of a long process, but we will begin our work following this meeting. Medicaid will then begin our work on evaluating these requests, also some considerations we may have internally, and then do our internal work to put those up through the department to send to the governor. So you may not hear anything or see anything for many months, which is the same thing that happens to us when we submit things to the governor's office. We have to wait until his budget proposal is released, but we appreciate your participation now today. So with that, Dr. Brinton, I think we're ready to get going.
Great. You see a little timer there. So we'd like to give each of you up to 5 minutes to do your presentation. And we'll start today with Deb Brugman from Foundation Medicine.
Thank you so much. I am a genetic counselor working with Foundation Medicine, specifically in the space to expand access for our testing for Medicaid beneficiaries and others across the country. Next slide, please. For anyone who's been affected or had a family member affected with cancer, you recognize well how complex cancer care can be, and it continues to get more and more complex. Today, I'm going to focus on the genetic aspect and the personalized medicine perspective that treats each person's individual tumor, as well as the progression or recurrence of that cancer individually. Next slide, please. So molecular testing really enables that personalized medicine aspect. So you can think about the testing as a key that can unlock the door to identify the patients who might be eligible for the targeted therapy. So the molecular genomic profiling enables us to know which patients have the markers or have the cancer drivers that would likely respond to the targeted therapies, and equally which patients don't have the markers and wouldn't likely respond to those cancer or to those treatments. Next slide. And this just shows how much that space has increased. The biomarker-based targeted therapies has more than doubled since 2020, and it continues to increase. Next slide. Here are the current recommendations from the National Comprehensive Cancer Network, as well as the American Society of Clinical Oncology, and 3 additional separate publications that all support the need and lay out the reasons why patients with cancer, particularly advanced cancer, should have access to this information to help guide their treatment decisions. Next slide. So Foundation Medicine has worked to develop a portfolio of tests. Today, I'm speaking only about Foundation One and Foundation One Liquid on the left. And that's because in the state of Utah, Medicaid beneficiaries already have access to the one on the right. Foundation One Heme is already covered in the state of Utah. So this request focuses on solid tumors or patients with advanced solid tumors. And the testing is available both by tissue as well as liquid. Tissue meaning they take actually the biopsy specimen or a surgical specimen and run the testing on that. Importantly, it can also be done through the blood or plasma. So looking for the tumor DNA that has been shed into the bloodstream, and that's important for patients who can't undergo a biopsy. Maybe the tumor is inaccessible. Think about a brain tumor maybe, or the patient is otherwise not healthy enough to withstand surgery for those reasons. Thank you. So the testing aligns or would help align with the goals from the Utah Comprehensive Cancer Plan. There's a call for increase in health equity, as well as providing access to high quality healthcare for all Utahns. So I've taken some excerpts here where Foundation Medicine testing could help answer and address those concerns. Next slide. The genomically matched therapies, and again, these are the therapies that the testing helps unlock or avail opportunity for. We can see through the studies done to increase progression-free survival, increase overall response, and increase overall survival. So there are definite advantages when the patients can have the testing to know whether they would respond or not. Next slide. This shows the difference in disparity. So in the dark bars, it shows patients with advanced non-small cell lung cancer who had commercial insurance, and in orange, those patients who had Medicaid. And you see that Medicaid lags behind in being able to access that information. And that results in a higher risk of not receiving those medications and a higher risk of mortality. Next slide. This is a slide to remind me that there is broad coverage with commercial health plans as well as with Medicare. There's a national coverage decision memo that lays out the criteria that I have on the next slide. Additionally, there are 26 states across the country who currently offer coverage for these tests. And this shows the PLA codes, which are specific CPT codes for the FDA approved companion diagnostic tests that I've spoken about today, where they're not yet covered in Utah. However, 81455 and 81456 are covered. Thank you.
Thank you so much for your presentation. Next we have Maggie Braumer and Kendall Bryce with Hanger Clinic.
Maggie, I think, was having a little bit of trouble with connectivity a couple minutes ago, so we'll just make sure she's able to be on the call, and if not, I will jump in and take her place on those first couple slides.
I'm back. Sorry about
perfect.
that. I hope that doesn't happen again, but thanks everybody. My name is Maggie Baumer. I'm the leader of Enterprise Patient Advocacy at Hanger Clinic, joined by Kendall Bryce, who's a certified prosthetist orthotist, along with Justin Bova, who's with Cranial Tech. And we're here to talk about cranial remolding orthoses, which are otherwise known as cranial helmets for head-shaped deformities in infants. This is a covered item, so we're talking about an increased reimbursement rate today. So I'm going to hand it over to Justin for the next slide.
Thanks, Maggie. So since 2023, 7 states have taken action to increase Medicaid reimbursement rates for S1040. So the average reimbursement rate amongst these 7 states is $2,341. So Utah currently sits well below that at just $1,221, which places it in the bottom 3 nationally and 42% lower than the national average of 2,107. Next slide. So this is showing everything that goes into S1040, which is an all-inclusive rate. So this is not just a device, it's a bundled service that includes clinical evaluations, multiple imaging sessions, digital design and customization, fabrication, weekly follow-up visits, and outcome reporting. It's a time and labor-intensive process, and it's delivered by licensed clinicians. Next slide, and back to Maggie.
Yeah, thanks, Justin. So we did meet with the Medicaid department directly to talk about reimbursement increases, and they had asked for our acquisition costs, which we are unfortunately unable to provide because that is proprietary information. However, these are bundled payment items, so the reimbursement we receive goes to cover the cost of the acquisition, along with all of the clinical care, administrative care, and overhead. And Kendall's going to talk more about the clinical care piece, but certified prosthetists and orthotists go through a master's degree program, and their training is extensive. So they are highly trained healthcare professionals providing this care. And so we do request that, since the rate is currently close to around $1,200, that we try to get as close to that $2,000 mark as possible. We realize this is a substantial increase, but again, it will enable us to provide this type of care to Medicaid beneficiaries and not do so at a loss to our clinicians. Next slide, please. So just to give you an overview of what the environment is like in Utah, there are 4 separate companies that I could find that are accredited to provide this type of service, 10 of which are Hanger facilities. And those are largely clustered around Salt Lake City, within 2 hours of Salt Lake City, although Hanger itself does have offices in Providence, Saratoga Springs, Spanish Fork, and St. George. So it just gives you an idea of, this is a relatively small group of people that are able to provide this service. And we want to be sure that we're able to keep as many of those facilities operating to provide CRO as possible. Next slide, please.
All right, I'm Kendall. I'm a certified prosthetist, orthotist practicing in Salt Lake City here. Next slide. So again, just reinforcing, it is highly specialized care that we provide. Hanger's created a national network of cranial specialists, and each of our 10 facilities here in Utah have clinicians that have practice in this specialized realm of our scope. Next slide. So being that this is a Class 2 FDA device, which is considered not safe except under the supervision of a practitioner, we make sure to follow up with those patients regularly, and then kind of illustrate the extent of care in the next couple slides here. So it takes about 8 to 12 clinical hours to go from eval to graduation with each patient, not including the administrative time to provide care. So clinical picture: at an eval appointment, your clinician will take in all sorts of information, from birth history to how the parents feel to what the 3D scan takes, and consider that in the context of published academic literature and clinical practice guidelines to create a custom recommendation for the patient. Next slide. And I know I'm running down soon. Delivery takes about an hour to really adjust that helmet. We trim these by hand and then follow up. Next slide. We see each patient every month to rescan, measure their head, adjust the helmet by hand, make sure there's always continued room for them to grow into. So it does take quite a bit of time there in all of those appointments. And that's it. Thanks for your time.
All right, thank you so much for your presentation. Next up, we have Stephen Hatch with Ivory Anesthesia.
Hi, my name is actually Tanya. Stephen is our owner. I'm the managing director, but Stephen got caught in a long case today and asked me to fill in for him. So what we are proposing is introducing a facility fee code for in-office anesthesia providers. What our company does is we are one of 3 companies along the Wasatch Front that does in-office dental anesthesia and accepts Medicaid patients. But currently we cannot bill for any sort of facility fees. Those facility fees cover things like the anesthesia machines, the supplies, the drugs and monitors and emergency equipment, the pre-op and recovery nurses, scheduling and billing staff, but we can't bill for that. The reason this is becoming an issue for us is because we have to keep our anesthesia providers happy, and they are a lot of times complaining about the low reimbursement from Medicaid. We've even had providers quit and go back to hospitals because we cannot keep up with the hospitals, whereas we can't bill for that facility fee. Hospitals can bill for the facility fee, and often that costs $1,000 to $2,000 for that facility fee. And what we're proposing is a much reduced facility fee for the dental and the in-office dental anesthesia providers. And that would save Medicaid. We've estimated approximately 5,000 cases annually between the 3 groups that we know of that do this. And if we can save Medicaid anywhere from $700 to $1,700 on a case, that's millions each year that it would save Medicaid. As we are dealing with the low reimbursement fees for the in-office anesthesia, as we have providers quitting and moving back to a hospital, we have to drop the dental offices that are doing a lot of Medicaid cases and can no longer serve those patients, which means they would then have to go to the hospital to have that anesthesia done for the dental work. And that would increase the cost to Utah Medicaid to do that. We currently treat a high volume of Medicaid patients, and we want to be able to continue to treat those. The patients we typically are treating are young children, special needs adults, and Medicaid patients in undeserved areas. And we'd like to continue serving those, but without facility reimbursements, that is becoming more and more difficult. Currently in Montana and Washington, they already have they already pay in-office anesthesia facility fees, and we are hoping that Utah can follow their lead and help us to protect this community and help them have access to the care that they need by increasing or creating an in-office facility fee for dental anesthesia. Does anyone have any questions? If not, I think that is it. Really, we just want to be able to continue to serve these Medicaid patients, and we want to be able to provide the care that they need, as well as saving the state millions of dollars by keeping them out of the hospital when they don't need to be there.
Thank you so much for the presentation. Appreciate that. Next up, we have Ali DaCourcio, NeuroPace. You can correct the pronunciation of your name.
Nope, you got it right. Thank you. I appreciate the opportunity to present today. NeuroPace manufactures an implantable neurostimulator for the treatment of epilepsy. The neurostimulator provides responsive stimulation, so you can program the device to this patient's specific needs. And what we're asking for is just coverage for 2 specific CPT codes. All of the other CPT codes associated with the therapy are already listed as covered in the Utah Medicaid fee schedule. So we are asking, our specific request is to change the coverage status for CPT code 61863 and 61864 from not covered to covered in the fee schedule. These codes describe the implantation of depth electrodes in the brain for connection to an implantable brain neurostimulator. The therapy is responsive stimulation, and it involves the use of the RNS system, which NeuroPace manufactures. It is a medical device with implantable electrodes and an implantable brain neurostimulator. Both the electrodes and the neurostimulator need to be implanted and connected for the system to function. The not covered designation results in either a delay in treatment as providers work through the appeal process, or a barrier to access altogether if the appeal process is unsuccessful. As I mentioned, all of the other relative CPT codes associated with the therapy, including 61850 and 61860 for the implantation of strip electrodes, are listed as covered in the fee schedule already. As well as 61863 and 61864 are listed in the fee schedule and have an associated payment rate, but they are listed as non-covered. And the majority of Medicaid programs across the country are consider these codes covered codes and are paying them. Next slide, please. Just quickly, an overview of the RNS system. As I mentioned, it has an implantable neurostimulator, and then you can, the physician can choose to implant either depth electrodes, strip electrodes, or a combination of the two. Once implanted, physicians can program the device to detect specific electrical patterns, and then it releases stimulation to normalize the electrical activity and prevent seizures. Next slide, please. So to get into a little more about the procedure and the codes that we're talking about, to implant the neurostimulator, the physician will do a craniectomy, which means you remove a portion of the skull. They insert a tray in that area, and then the neurostimulator is placed within that tray and secured. That's reported with CPT code 61889, which is listed as a covered code already. Then the physician determines the appropriate leads to implant, whether they're going to be depth and or cortical strip. For depth leads, the CPT codes, as I mentioned, are not included as covered codes. They are included in the fee schedule. They're just not covered. But the procedure to implant the strip electrodes are with 61850 and 61860. So once you implant these, you connect the leads to the neurostimulator, and it's the only way that the device can function if you have both the leads and the neurostimulator implanted. Next slide, please. So this is just what the current Utah Medicaid fee schedule looks like. You could see all the codes associated with this therapy are covered except 61863 and 61864. And our physicians are having a difficult time getting authorization to proceed with this procedure when it involves the implantation of depth electrodes. So we would like to request that the coverage status be changed to covered. Thank you.
Thank you. All right, next we have Mary Ann Neff with Northern Utah Case Management.
Hi, I'm presenting on both the Independent Support Coordination Association and the EPASS program. It looks like you have the EPASS up first, so I'll go with that one. So in regards to EPASS, I'm one of two providers in the state of Utah that offers case management. And since the inception of the program in 2008, there have been no rate increases for support or for case management services, with the rate being at just under at approximately $23.28 per hour. Just for reference, this is below staffing standards for waivered services in terms of direct care staff. And so it's becoming increasingly difficult to be able to find case managers that are willing to work with such a low rate that isn't comparable to the industry standard. Right now, we are asking for a 40% increase because the rate has been so overlooked for so many years. And we are facing dare I say, a cliff of providers that are not available. Currently within staffing, we do not have any providers to do direct care staff outside of self-administered services throughout the state of Utah. And we offer services throughout the entire state within our personal company. We were ranked in the top 10 in 2024, but that was the year that nobody was funded for anything. And we were excluded from last year's rate increase with the aging waiver. So I am asking that this be considered again for services, but I would actually propose that this be looked at as a waiver, as that would be cost efficient for the state to be able to take existing funds and turn it. We anticipate on our caseload alone, approximately 80% of our clients would be eligible for a waiver within nursing home or ICF standards. I'm going to switch over to support coordination because I have 5 minutes for just both. I am the legislative representative for the Independent Support Coordination Association. We are asking for a 40% increase because of how low our standards of rate is. We are 3% above what our rate was in our inception in 2009. We estimate a high level of cost to be able to bring on new support coordination, and the majority of companies are not offering benefits but want the ability to do so to be able to retain quality staff. We have presented to the legislature on multiple occasions. We did have a rate reinstatement, and that was in conjunction with a rate reduction that happened during the recession. And since that time, since 2009, we've only had that 3% increase total. The reason that we are asking for an increase is threefold. The first is that just speaks for itself, is that 3% increase, which is below industry standards. However, the second would be that we have had a substantial workload increase over the course of several years. And these are issues that we have talked with DSPD about, and they are so important for the health and safety of our clients that they cannot be reduced. But it is adding an increased burden onto support coordinators that we do have a concern about the viability of our industry to be able to ensure the safety and health of all these clients statewide. Specifically, you'll see on the column in number 2, the workload has increased to include the settings rule, employment law. We've had a massive increase to database expansions, budget reduction requests that the legislature requires of us, increased caregiver supports, new assessment tools that are required, and we're seeing a drastic increase of mental health clients that have exceptional needs that struggle to be met within our industry standards. The main concern that we have in this structure is that when we present to the legislature, we have to do so with that representation. We have talked to representatives, we've had tremendous support from them, but they have told us that within their own budget legislatively, there is not a lot of extra wiggle room for additional supports that are not on the governor's budget. And for that, we are coming to you directly because we were included in the 2024 request for services. We were within the top 15 for a rate increase. It was the year nobody got any funding for anything in social services. And that is something that this last year, the representatives just said, you've got to go through the max budget because we are struggling to be able to find any additional funding within Social Services Committee to be able to appropriate. And so that's why we are coming to you this year, even though we have worked with legislators in the past and have had a very good response up to date. The final concern we have is for sustained growth. We have over 4,700 people on the individuals on DSPD's waiting list. And in order to support those individuals, all of them have to have a support coordinator coming into services. And we want to be able to grow to sustain that need and to have a very healthy industry. And at 3% rate increases, we cannot sustain that. Thank you.
Thank you. Next, we have Dr. Erica Barnell with Geneoscopy.
Thank you for that introduction. As mentioned, my name is Erica Barnell. I'm the co-founder and chief medical and science officer at Geneoscopy. I'm here today to propose coverage for our flagship project, ColoSense, which is an FDA-approved test for colorectal cancer screening in average-risk subjects age 45 and older. Nothing's more exciting to me than to present to a group of individuals who clearly care about preventative medicine and specifically about the impact of colorectal cancer screening to mitigate morbidity and mortality associated with the disease. I read this initiative that was put forth by your team, and your goals are directly aligned with why we founded Geneoscopy in the first place. As you noted, CRC screening rates have significantly dropped since the pandemic, and resources need to be deployed to improve colorectal cancer screening rates to reduce disparities and save lives. Next slide. So here I am presenting ColoSense. It's a solution to combat low adherence with colorectal cancer screening. ColoSense is an at-home, non-invasive stool test that is FDA approved for colorectal cancer screening in average risk individuals aged 45 and older. It's first line recommended for detecting both colorectal cancer and advanced adenomas. And we've partnered with LabCorp to make this test widely available to physicians. Over the last year since approval, we've received a PLA code and CMS reimbursement of 509. We actually actively have coverage in 10 states for Medicaid. Next slide. Briefly, I wanted to provide an overview of how ColoSense works. Subjects are prescribed a ColoSense test, and a test gets shipped to their doorstep automatically through our manufacturing facility. We provide instructions on how to complete that test and have it shipped back to our centralized laboratory. In the lab, we process the sample and provide results to the patients and providers. Next slide. The ColoSense test is highly accurate for detecting both colorectal cancer and precancerous adenomas. In a prospective phase 3 clinical trial of nearly 9,000 patients, we achieved 93% sensitivity for detecting colorectal cancer, 45% sensitivity for advanced adenomas, and 88% specificity for no findings on a colonoscopy. These data were published in JAMA in 2023 and served as the data to enable FDA approval for the indication that we have provided here for your reference. Next slide. Importantly, at Genoscopy, we view adherence to be a pivotal component of our test. As part of our offering, we provide services to the patient from start to end. This includes having a medical team that not only aids subjects in returning a ColoSense kit back to our laboratory, but if that test is positive, we provide patients with navigation services to ensure that they go on to receive a colonoscopy to have lesions removed. This is a service that, again, we provide pro bono to patients to ensure that they have comprehensive colorectal cancer screening and making sure that the non-invasive test, again, if positive, results in a colonoscopy. Next slide. For your reference, I've provided 3 manuscripts that highlights ColoSense clinical validation that, as mentioned, was published in JAMA in 2023, analytical validation to demonstrate the robustness of our assay, and most recently, there was a health economics model that was published externally through an unbiased consortium, whereby they demonstrated that the ColoSense accuracy profile demonstrates benefits with regards to improving outcomes and mitigating healthcare costs that are associated with late-stage diagnosis of colorectal cancer. Next slide. These are the references for my entire presentation. Next slide. And with that, we're formally requesting that ColoSense be covered by Utah Medicaid at our 509 rate. Thank you so much for your attention.
Thank you for your presentation. Next up, we have Julie Hadlock and Dr. Jennifer Mitchell with the Children's Center.
Thank you for the opportunity to present to this committee. My name is Jennifer Mitchell. I'm a licensed psychologist, and I specialize in infant and early childhood mental health. And I am joined by my colleague, Julie Hadlock, who's Director of Operations with our organization. Next slide, please. Since 1962, our organization has led the way in providing comprehensive mental health care for children birth to 6 years and their caregivers. Our treatment is trauma-informed, evidence-based, and it's tailored to meet the very individual needs of each child and family that we serve. Mental health, like physical health, spans a continuum, and there's a myriad of factors that influence a person's relative health. The foundation of all learning and all development for young children happens in the context of their earliest relationships, and that really becomes the starting point from which all later health manifests. We are all familiar with the Adverse Childhood Experiences study and ultimately the profound impact that adversity in the early years has on the developing brain of a young child. And the field of infant and early childhood mental health recognizes that the best way to prevent these significant negative long-term health outcomes is to ensure access to necessary mental health treatment right from the start. Next slide, please. Now more than ever, families need support, and Utah is among a group of states with the highest prevalence of child and adolescent mental health disorders and the highest prevalence of untreated mental health needs in youth specifically. Nationally and in our state, as many as 1 in 5 children experience mental, emotional, developmental, or behavioral challenges that can have a lasting impact on their well-being. And with suicide as the leading cause of death for children ages 10 to 17 years, the time to intervene is now. And we need to get upstream to provide treatment options to families long before it rises to the acuity of suicidality. It costs less to intervene early, and the positive impact on families when we address the concerns in early childhood are priceless for all. Next slide, please. We provide a range of services, including outpatient family therapy, parenting groups, psychological and psychiatric evaluations, and an intensive therapeutic preschool program. The treatment that we provide is central to solving the mental health crisis that we have in our state. And by providing these necessary treatments to our most vulnerable young children, we can help to ensure that every family has what they need to raise strong, resilient adults. And next slide, I'll now turn the time over to Julie.
Thank you, Jennifer. As truly the experts in the state of Utah in infant and early childhood mental health, we want to be able to find a way to continue to provide these amazing services to more and more clients in a sustainable way. And as you can imagine, to deliver these services is expensive when we're talking about this level of expertise. So our ask involves a rate increase of some codes that we're currently billing for. So first of all, family therapy billing codes actually reimburse at a lower rate than individual therapy billing codes. And obviously family therapy is a more complex situation to find yourself in. And so the request is that family therapy codes be reimbursed at least the similar rate as individual therapy codes. Additionally, when we're talking about doing treatment with young children, this is with caregivers, with families. It's attachment based between children and their families. And so this is dyadic treatment, which is significantly more complicated. And as Jennifer mentioned, is using evidence-based treatment models. And so the level of training, of supervision, and of monitoring for fidelity to evidence-based treatment models makes this a much higher level of care. You're going to get much better outcomes, but it's more expensive. And so a modifier for dyadic treatment using evidence-based treatment models, when working with ages birth through 5, there's a handful of states that are doing work like this and others that are looking to add this. There's an existing interactive complexity code, which is an add-on code that currently is open but has 0 reimbursement rate. So this is something that recognizes when you need interpreters in the room, when you're using therapeutic toys that makes it more complex. We would like a reimbursement rate on that. And then our psychosocial rehabilitative services code is that in that therapeutic preschool program, which is essentially an intensive day treatment program that's costly to run, and we would like a reimbursement rate increase on that per unit service. Thank you so much.
Thank you. Next, we have Andrew Riggle with the Disability Law Center.
Good afternoon, members of the committee. I'm sorry if I sound like a depressingly familiar broken record. Utah can't afford for suicide prevention or crisis intervention to be its only response to serious mental illness. The state must develop a system designed to prevent crisis hospitalization or incarceration. Individuals with a mental illness made up almost 41% of unhoused persons identified during Utah's 2023 point-in-time count. Nearly 500 of them were unsheltered. At that time, there were only 336 permanent supported housing beds available. This is why, even in these uncertain times, we urge the MAC to prioritize $72 million $72 million, which when added to the $55 million allocated by the legislature in 2022 totals the governor's recommendation of $127 million for deeply affordable and permanent supported housing from that year. We further encourage that it be integrated and scattered site. We also asked the committee to prioritize $2 million for the four additional local mental health authorities that expressed interest in assertive community treatment teams in response to Representative Judkins' HB 248 from 2023. Ultimately, we must develop a system that delivers the right supports at the right time and in the right place. Individuals leaving an ICFID with conditions requiring a higher level of medical care can continue to receive nursing services. However, those needing a similar level of care already on the community supports waiver or about to age out of the tech-dependent waiver at 21 aren't so lucky. The DLC would appreciate the MAC prioritizing this $4 million request highly once again. Conversely, young adults on the TDW can't access supported employment, day programs, or other DSPD supports needed to be fully participating members of their communities. If we assume about 100 of the 145 individuals on the TDW will take advantage of these supports for 8 hours a day, 3 days a week, the total state cost could be around $2,605,100 annually. Even though we appreciate this year's $6 million for the DSPD waiting list, the limited supports waiver, and family peer support, there are still about 6,000 individuals on the list. Therefore, we request the committee prioritize the other half of Social Services Appropriations Committee's recommendation in the amount of $6 million. Likewise, we supported the $1,225,000 in state money for Representative Lund's HB 324 from 2024. Its pilot could prevent or delay the need for more intensive support by offering Medicaid state plan services earlier to 124 families on and off the waiting list. Individuals using self-directed services, non-DSPD providers, or the New Choices waiver continue to have trouble recruiting and retaining qualified direct care staff. While this year's $1 million rate increase for home health will be welcome, it amounts to merely a 6% increase when inflation has gone up more than 21% since the last increase over 6 years ago. Therefore, we ask the committee to at least prioritize the governor's original recommendation of nearly $3 million. Thank you for your time and considering our requests.
Thank you. Next up, we have Nicholas Doucette and Steve Strand from Novocure.
Hi there, this is Steve Strani, and I think you're just stuck with me today because of Nick's on a flight right now. This request involves coverage for tumor treating fields, which you'll hear me refer to TT fields throughout the presentation. TT fields are a novel wearable anti-cancer therapy that can be used in addition to chemotherapy, radiation therapy, and surgery. So this is an item of durable medical equipment that the patient self-administers at home. TT fields is a proven therapy for the treatment of glioblastoma, a form of brain cancer, and non-small cell lung cancer. And it does not have the systemic toxicities that are associated with other forms of anti-cancer therapies. And TT fields relies on alternating electric fields that are tuned to cancer-specific frequencies to disrupt cancer cell division while sparing healthy cells. The electrical properties of the cancer cells are key to the therapy, and the therapy it does not actually transmit electrical current through the body, but it's the electrical fields, for those of you who remember taking physics years ago, and the electrical fields interfere with cell division of the cancerous cells, leaving the healthy cells untouched. There are two forms of the commercial product. One is used for brain cancer. It's referred to as the Optune Geo. There are the slides. I'm at slide 5 now. If one more, maybe one more. There you go. So this shows the arrays that are placed either over the skull for brain cancer or on the chest wall for lung cancer. If you could go to the next slide, and in fact, maybe skip to the one with the words there. So with respect to metastatic non-small cell cancer, the studies have demonstrated that when used concurrently with a type of chemotherapy called immune checkpoint inhibitors or docetaxel, a increase in overall survival of 3.3 months, and in other instances, an increase in survival of 7.7 months versus the immune checkpoint inhibitors used alone. And again, there are no additional systemic side effects compared with the underlying drugs that this is used with. So the side effects that are sometimes associated with the therapy are moderate skin irritation. And this is an FDA-approved therapy. If you can skip forward, please. Why don't we go ahead and skip over to the brain cancer slides? How about that one there? So similarly, we've seen with the application of the TT fields, a substantial 4.9-month increase in overall survival compared to the chemotherapy used alone. Can you skip forward for me to, why don't we go to the last slide and we'll finish up there. Perfect. So, yeah, that's a good one there. Wanted to highlight to you that TT Fields is covered across the country by Medicare and has been covered since 2019. It's covered widely by commercial plans and currently covered by 27 state Medicaid programs. So we urge you to add coverage in Utah under the Medicaid program.
Thank you. Next up, we have Bobby Ginn, or Jen, sorry, Utah Assisted Living Association. If you can help us correct the pronunciation.
Thanks, Jennifer. Thanks, Mac, for listening to our concerns. My name is Bobby Ginn, again and again, and that's how everybody remembers it. But I'm the current vice president of Utah Assisted Living Association, and we represent about 80% of the current current assisted living communities in Utah. This is an ongoing concern and an ongoing request for appropriations. And because a lot of our assisted living facilities are reducing or no longer accepting the New Choices Medicaid waiver, and we are concerned. And so we want to continue our concern and appreciate what the MAC has done for us in the past, and would love for their continued support on this effort. In a few years, there might not be enough assisted living communities to accept any of the Medicaid or New Choice waivers. Assisted living is obviously typically something for our seniors that caters to individuals who require assistance but do not need the intense medical care in skilled nursing facilities. And assisted living is an option for seniors that choose to maintain their independence while also benefiting from the support structure assisted living communities provide. Assisted living communities offer a variety of services that are designed to enhance the quality of their residents' life while keeping them out of expensive long-term skilled nursing care. At this point, we are asking for that continued appropriations. This year it was roughly $20 million, $7 million state ongoing money, and approximately another 14 or so million. And that is just a drop in the bucket of what's needed, but we'd like to continue asking for it a little bit at a time. Currently, the costs for assisted living is about $140 per day, depending on if it's assisted living or Medicare. A recent Myers and Stouffer survey indicates that the rate should be between $120 and $140. And currently, we are paid through Medicaid at about $79 a day. If we look, Utah's very low on the scale of what is paying out. Montana's up in the 118 range, Idaho in the 115 range, Arizona $115 per day. Again, that report says that we should be up over 120, closer to $130 a day, and we're down at $79 a day. The program started in the early 2000s and has had one increase in the last 25 to 30 years. If we don't do anything, we're going to have some increased challenges with more seniors in skilled nursing costing the state and Medicaid more money. We're going to have more seniors going to the emergency departments. We are going to possibly have a lot more homeless seniors in the state, which will cause even more problems as well. The silver tsunami is what we like to call it, is coming, and it's started. In the next 30 years, the population growth of people over 85 is going to increase by 200%. And we need to start being more prepared for their needs. Currently, assisted living is great because it's a cost-effective way to do business and support our seniors. Assisted living is about $5,000 a month compared to the approximate $10,000 a month that nursing homes cost, and approximately $24,000 that it could cost to have an in-home caregiver. Assisted living matters because our residents love being in assisted livings. 90% of residents report high satisfaction, 95% feel safe, 70% of the seniors living in assisted living report improved health. The baby boomers are going to fill in with private pay to our assisted living soon. And we are going to have to either build more assisted living communities and or increase the New Choices waiver rate. So we are asking for more appropriations so that our current rate of $79 a day can be closer to $100 or $120 a day. It's a needed thing, and we need to do it soon before it's too late. And on behalf of the Utah Assisted Living Association, we urge the MAC and DHHS to continue to push towards a large daily rate increase so Utah's low-income seniors will continue to have the choices in the future. We appreciate all you guys do. Thank you.
Your presentation. I see that Brian Monson has raised his hand.
If that's okay, I'd just like to ask a couple of questions. If now's a good time to do that. Tell me again, how many assisted living centers in the state that take the New Choices waivers right now?
So there's roughly 225 to 250 assisted living communities, and it's dropped by about 10% in the last 2 years. And we haven't done any of the data for how much it's dropped in the last 6 to 8 months, but as of last fall, 10% of the communities have stopped accepting New Choices programs or residents into their communities.
Yeah, so there's not 250 assisted living centers accepting the waiver right now.
Correct. That's total number that could be accepting the waivers.
And how many actually do accept?
It depends, and there's not a specific number. There's approximately 1,900 New Choices waivers in the state of Utah right now. It goes between 1,800 and 2,000 approximately. The state has more of those specific numbers.
You're talking in terms of the clients, the number of clients,
right? The residents.
I'm talking about the actual number of facilities. Like, is there 25 that are accepting clients right now under the waiver?
I do not have that right in front of me. I can get that to you
Okay.
or to the committee for sure.
You did get some new money last year, right?
We did not. We were really close last year, and we got to the 11th hours, and they cut it out at the final appropriations committee. The executive appropriations committee did not approve the money that was requested by Jennifer, DHHS, MAC, and then governor.
Yeah. Okay. No, that's fair. Because I was hopeful that maybe you did have some money. You'd see more centers opening up to accept new clients. So
Absolutely.
I have a real interest in this. So perhaps maybe I could talk with you about it another day.
Thanks, Brian. We'd love to work with you, get more information and to you.
Thank you.
Absolutely. Thank you.
Thanks. And next looks like we have Allison Richmond with a question.
Yes, I actually am a case manager with the New Choices Waiver Program. And what we're seeing in Cache County and Weber County is a lot of facilities are not willing to accept the amount of income that the clients can give. And because this is a program for low-income participants, a lot of them are living on Social Security only. And so I have some clients whose income is less than $800 a month. But a lot of facilities, because they're only being reimbursed, $1,200 to $1,500 a month or whatever, they are asking for the clients to pay that full amount. And so what we're seeing is we're running out of options for these people, and they are going to be moving into skilled nursing facilities when really the assisted living facility can take care of their needs so much better. So I'm really hopeful that some changes can be made, because it's a wonderful program, and the assisted living facilities in so many situations really fulfill the needs of those seniors.
Thank you. Any other questions before we move on to our next presenter? Okay, our next presenter is Joey Ulrich with Choice Home Medical.
Hi, yeah, my name is Joey Ulrich, and I can vouch for the past presentation as well. I see a lot of that, and we work together on a lot of these different things. And I am presenting as a consumer representative for Medicaid recipients. I work for Choice Home Medical, and we serve everybody from children, adults, and seniors. And the purpose is to secure rate increases for critical supplies to address rising costs that just continue to skyrocket, worse patient health outcomes because they're not getting the supplies that they need, and reduce quality options. We're having to discontinue a lot of brands and a lot of different, absorbency levels because they're too expensive, and Medicaid won't reimburse for them any longer as the rates or as the prices continue to rise. And so the focus is incontinence supplies, nutritional drinks, and New Choices waiver supplies. Often, a lot of these things are called soft medical supplies. Next slide, please. Go back one. Yeah, there we go. So as far as I can find, there have been no increases since 2015. And I think it goes back even farther. What I could definitively find is there's not been anything for sure since 2018. So that the next slide is going to blow your socks off. And if we can go to that next one. And I try to break it down from 2015 to 2025 on all the main supplies people are getting. And if you can see, I did the last two columns, 2020 to 2025, to see how things have skyrocketed just in those 5 years. And then the 2015 to 2025, I mean, we're obviously not keeping up with no rate increases, but we're having, you see nitrile gloves, 213%. We can't get those anymore. And a lot of people have allergies, but Medicaid will not cover those. It's just virtually impossible. And pull-ups are obviously a huge important thing for our seniors and anybody using them. And they can't get overnight pull-ups. They can't get the really good absorbency, and that's causing a lot of problems, as Bobby again could vouch for on a lot of this stuff. And so you can see these price increases. Not only are the prices increasing, shipping has gone up about 60%. It says 50% here, but I got better information from some of our suppliers, and it's gone up about 60% in the last 10 years. And they just came to me last week and said they're going up another 6%. So next slide, please. So some of these consequences are low quality alternatives that I've mentioned. We have to get vinyl gloves. That's all they can get. And so they're using more of these other supplies that are lower quality, and it's causing more, I think in the long run, it's definitely causing more spending by Medicaid, because they're taking, instead of like one overnight pull-up, they're taking a pull-up and an insert pad, putting them together, and it's still not doing the job correctly. So they're just blowing through these, where we could just get like one overnight pull-up and it would be half the cost of everything else they're trying to use to compensate for some of the issues that they're having. They're having worse patient health outcomes because they're getting bed sores. Their personal hygiene is really decreasing because they just don't have the right supplies, and it causes them a lot of distress. It's their whole world. This is the number one thing on their mind. And I'm running out of time, so I'm gonna go a little bit faster and just skip to the last page here to talk about the proposed rate increases. You can see some of these rate increases, and I had to generalize a lot of it because it changes depending on the size, depending on the absorbency and different things with HCPCS codes. But these price increases are even less than the rate increases that we're asking for are much less than the price increases we've seen over the years. And so I really hope that we can analyze this and really get some increases, because at some point we're not going to be able to get a lot of these supplies, just like the nitrile gloves that we've just discontinued completely. And if we can go to that last slide here. So if we can't get these price increases, we continue to have our distributors coming. I just had them come last week and say, we're going up. We're going up another 6% in shipping. We're going to increase our pricing. We've held it down too long. And they're even saying they're losing money on our account because they've been holding our supplies so low for so long, and they just can't do it anymore. So they're really advocating for an increase in quality of supplies and rates. So thank you for this opportunity. I appreciate it.
Thank you. Next up, we have Matt Hansen.
Thank you, Dr. Britton. I am here not with a formal request, but I asked Sharon if I might be able to come in and kind of report back to the group. We have been before the MAC in the last 2 years, and were recommended by the committee and included in the governor's proposed budget for an increase to HCBS waiver rates in the amount of $2.9 million in general funds, and to home health reimbursement rates in the amount of $1.9 million in general funds during the last 2 years. In 2024, we did not receive any funding from the legislature, despite being the governor's budget or proposed budget and favorable positioning when we went into the EAC, or the Executive Appropriations Committee. So consequently, we had a lot of conversations with leadership, and we're told that our best chances of funding in 2025 would be to make our request budget neutral. So we did just that and came up with a solution with the Medicaid department and our sponsor representative, Ray Ward, to eliminate the rural enhancement multiplier for personal care services, and pass intent language that those savings would be reinvested in home-based services to increase the reimbursement rates throughout the state. So the elimination of the rural enhancement multiplier actually saves the state $13 million in ongoing funds. And again, our request was for 2.9 for the HCBS waivers and for 1.9 for home health. The intent language was adopted by the Social Services Appropriations Committee, but when all was said and done by the end of the session, just $1.1 million in general funds were appropriated to the HCBS waivers, and we didn't receive anything for the home health rate increase. So we've had a lot of other conversations since the end of the session, and have been told by elected officials that the intent language was slotted for adoption by the EAC as well, and everything looked good going into the last 3 days of the session. However, Medicaid's quarterly budget, the timing of that was during the third day before the end of the session. And when that budget report came out, and revealed the deficit of $28 million. The committee members we spoke to said it caused a bit of a panic and essentially threw all assurances that we had been given out the window that we had been given previously. Because that $13 million in savings that we had hoped for was needed to help to pass a neutral budget, and because they are ongoing funds, our strategy this year is to give other good causes a chance through the MAC process and work directly with the department, the governor's office, and members of the social services and executive appropriations committees to try and tap into those savings for an increase in 2026. Again, they are ongoing savings. We didn't get it last year. We're hoping some of those, by our elected officials, the intent to use those savings to help to increase the rates throughout the state where they're needed and preserve programs will be honored. But I just wanted to come before the committee again to kind of explain the situation. It is a complicated one. We do appreciate your advocacy and support. The last 2 years helped to get us into the governor's proposed budget. And even though we didn't get the funding we were hoping for, we're going to keep fighting and appreciate everybody else who's been here today. There's so many good causes and listening to them is very humbling. Thank you.
Thank you. We appreciate all of your presentations. There are so many good causes, and we appreciate how so many of you help us to save money long term, right? By investing early. Next up, if there are no questions from the committee members, next up we do have Michelle Smith with an eligibility and enrollment update.
Yeah, hi. Thank you, Jennifer. I will go ahead and display my screen. Okay, hopefully you all can see that okay. I'm going to focus again, as I always do, just on the person part of the enrollment report. So if you look as of April 2025, our total member count is at 354,957 individuals. If you click over to the more they're broken down by program and coverage type data table. I looked through this. I didn't see any significant changes. We still do see children pretty steady, and I think some slight movement, an increase from child Medicaid onto CHIP. So CHIP is steadily, just slowly but steadily seeing a slight increase. But no other significant changes to point out on this report. I will go ahead as well and drop this into the chat. This is available for those of you who may not be aware on our website and gets updated every single month. I will also share our dashboard that has information on outcomes, and some of the movement that occurs as well. I will also just quickly share this report was on our 1115 waiver. So all of the programs, whether that be eligibility, enrollment, or benefit, are captured on this dashboard. This was a request that came out of the MAC, and this gets updated every single month. So I will drop this dashboard into the chat as well for those of you who want to take a look. This is also available on our website. But I'll go ahead and pause there and just ask if there are any questions. You're welcome, Steph.
All right, thank you so much. We have time now for our director's report from Dr. Jennifer Strohecker.
Hello, everyone. Wanted to just focus one area today and give an update on the congressional budget recommendations that are currently in discussion and moving their way through the process. I have a pretty comprehensive slide deck that I will share. I don't want to present it here in the meeting because I feel like it's just too much content, but I would like Sharon to just distribute it afterward. But I want to walk through verbally some of where we are in the process and give an update. One of my considerations with just even bringing this to the discussion today is that this is absolutely still in discussion. So as we can go about presenting and sharing what we know and where we are, I do think it's really important that this is actively changing, and even the slides that I have now have already been modified. But I do want you to know it's moving through the House committees, through the markup process, and soon ready for a vote on the whole package. One thing that I think is helpful in the context of many of the discussions that are now, of course, focused on sort of hitting this $880 billion target, much of which may come out of the Medicaid program, is that there is a process. And I think I showed this last month just to show you the various steps that these items are moving through as we're looking at the different proposals and items that have been put forth. We know that this is a pretty lengthy process, of which we are right now in the committee marks up the bills, which is being finalized actually before it moves on to vote on the package. So they're finishing up the markup process, which is step 3 here is highlighted, and then moving forward from there. Some of the pieces I wanted to share, and their goals, of course, is to have a floor vote by Memorial Day, but that is, of course, next week. So we'll see where the conversation goes. Couple items, and I said I will share the comprehensive slide deck here afterwards. But some of the pieces I think are worth focusing on are top policy items that are put forth are mandated work requirements. And so wanted to just share this. Again, there's a lot more text available that I will share afterwards. I'm not going to go through all of this today, but I did want to share that in the time when this slide deck was put together, that there was a proposal to mandate community engagement requirements as of January 1st, 2029 for expansion adults. And there's certainly exceptions that are included here. It talks about the age range that they're looking at, but we suspected this may be part of the federal proposal coming out, a mandated work requirement. And we're seeing that in the package that is moving forward. Another change to the Medicaid program, specifically affecting expansion adults, is a proposal to impose cost-sharing requirements for this population. So as of October 1st, 2028, we would be required to impose cost-sharing on adults with incomes over 100% of the federal poverty limit. And of course, some more details are below here. But that is, there are some exceptions as we have down here at the bottom, if you're looking at primary care, prenatal care, pediatric care, and emergency room care. But otherwise, again, this is a new requirement. States can do this now, but not all states do. And this would be a requirement to do this for expansion adults. Another change, again, this is looking at adult expansion, is that it would require eligibility redeterminations every 6 months. So this is the top text here as we're looking at this piece of the legislation, and this proposal is that adult expansion individuals would be required to go through a review every 6 months. Today, it's every 12 months. But so if you consider that there is a work requirement mandate on this population, new mandated cost sharing requirements on the population, and then ongoing eligibility redetermination conducted at every 6 months. Another additional change that's been put forth is that today, when someone gets retroactively enrolled in the Medicaid program, we can go back 90 days and turn on their Medicaid coverage 90 days retroactively. This would limit that so that we would not go back 90 days, but it would be a 30-day just a 1 month retroactive coverage. And then there's other things here I won't spend time going through, but it looks about getting accurate addresses, looking at duplicate enrollments across state lines, for example, and increasing some of our oversight in the program through some of these steps. A couple other thing I would like to call out. Let's see. There is some text around provider taxes and state directed payments. Again, this was an area where provider taxes have a ceiling today of 6%. And we in Utah have 4 different provider taxes: our hospitals, our nursing facilities, intermediate care facilities, and our ambulance providers. And today we have the flexibility or the authority to go up to a 6% on a tax. And what this does is it actually puts a moratorium on new types of taxes. So we have 4 today, but we couldn't move to 5 after this would be enacted. And we can't increase from where we're at. So it kind of stops where we're at the time of this bill going into law. It would stop us from going higher than that at that point. There's also a similar but related impact on state-directed payments. So what this looks at is that it says if you today have a state-directed payment in effect at the average commercial rate, or if you have a request that is submitted to CMS for consideration at the average commercial rate, then states can continue to pay a state-directed payment at that commercial rate. If you never exceed, it's technical, but you can never exceed the amount that you've been approved at one point. So it kind of establishes a new ceiling. For any new state-directed payment that is done after this legislation goes into effect, it would create a new ceiling of Medicare, a Medicare limit. So they're trying, again, to kind of control the growth of Medicaid and the costs, of course, associated with that growth by creating some new standards around taxes and state-directed payments. We've talked about this in the past, that one of the other proposals is that it would redact the nursing facility staffing standards rule that was put forth by the Biden administration, as well as parts of the eligibility rule. And this basically puts a moratorium on states being required to implement these up until the moratorium would go up 10 years. So you can see it prohibits CMS from requiring states to do and follow these 2 rules that were put forth by the Biden administration. This next item looks at individuals who are non-citizens, and for states that offer non-citizen coverage, and this is comprehensive coverage. This is not referring to emergency Medicaid. It's referring to, for example, our state CHIP program that offers non-citizen coverage to 1,800 or so children in the CHIP program. This proposal is directed at states who do have non-citizen coverage, comprehensive non-citizen coverage, and programs that support that. And what this proposal says is that it prohibits the federal match on individuals whose immigration status has not been verified, included during reasonable opportunity periods, but it also penalizes states who are providing coverage to non-citizens by reducing the 90-10 FMAP that we have on expansion by 10 percentage points, so that it would drop our FMAP from 90-10 to 80-20 if we were to continue to provide financial assistance or any sort of health insurance coverage to individuals who are non-citizens after October 1st of 2027. A couple other things that were in this proposal is that it prohibits the use of federal dollars for specific treatments for gender-affirming care for individuals under the age of 18. This looks specifically at medications and for surgical treatments or surgical procedures that could be given to minors for specifically the diagnosis of gender dysphoria. It does not limit the use of these medications or surgeries for non-gender affirming care diagnoses, but does restrict it for those. for those service types. There's a couple other things around providers and making sure we're staying on top of checking the master death file, making sure we're not having providers enrolled who have passed away and they're still billing for Medicaid services. One thing I would like to call out is that it prohibits Medicaid funds from being paid to certain family planning providers that offer abortion services and received at least $1 million in Medicaid payments in 2024. Example, Planned Parenthood. And so wanted to just call that out as a change in provider coverage. Additionally, just below that, they're trying to encourage provider enrollment for out-of-state pediatric providers and establishing streamlined processes and requiring states to do that for out-of-state pediatric providers. There's probably that is a bit of the update that I choose to share with you today. There's other sorts of oversight and other language that's been included in this deck, but I think for the most part, that covers the major policy areas. A couple things here on policy around just some policy program management things that we're already doing with regard to prohibiting spread pricing, and then also looking at participation in a drug pricing survey that happens nationally and mandating that. So again, these slides, some of you may say, well, those are outdated slides, Jen, and I have more recent information, and certainly that may be possible. I've already been told that the date of mandated work requirements has been moved sooner. So based on some interviews that have been said, but with regard to the data that I wanted to share with you on at least this week and the rapidly evolving discussions, I wanted to give you an idea of where we are in the process, and of course of the items that are potentially affecting the Medicaid program here. Does anyone have any questions? Go ahead, Andrew.
Hi, Jen.
Hi, Andrew.
Thanks for that. It's so much fun. And I'm just curious whether you have heard anything about this, or whether it's a part of the conversation among the state directors. But I noticed, at least in the, it looks like there is a change to how 1115s will operate, and that a new 1115 or a renewal of 1115 will only be allowed if it doesn't add to the federal cost. And of course, my brain immediately went to, well, our entire expansion population is in an 1115. Will this have any consequences for expansion?
Yeah, that's a really good question. I'm glad you brought that up. And I may ask for help from a friend here with Brian, because he's been on. So this is our budget neutrality process, Andrew. And there was a slide I jumped through pretty quickly around the 1115 budget neutrality. And what I was told, and again, all of the details of these proposals are, far from fully defined, right? But the one aspect is they are going to be looking more closely at the budget neutrality that states have put forth and do, I think we're seeing this across the board from CMS already, is that they are applying more scrutiny to the request, to the calculations that were submitted, and applying a greater rigor to what is being submitted and how those monies are being estimated. So, Brian, what else would you add to that? Because I know you're very involved in the budget neutrality process, and we've talked about this with CMS a bit.
Yeah, thank you, Jennifer. So yes, I think what I've read in the draft text was specifically about the treatment of savings that are generated through budget neutrality. an example of savings that was generated was from our non-traditional population that we've since 2022 given them full traditional benefits, but prior to that date, that non-traditional group was generating savings by offering them a lesser benefit. And today, all of the populations in our waiver are what CMS considers to be hypothetical, meaning that they don't generate long-term savings. We still have some accrued savings that we got from that non-traditional population, but the language in the draft bill seems to be directed towards populations, how states use, how they treat savings. That's a little bit, but it seems very directive to the federal HHS to define how to treat those savings going forward. So we will have to wait to get some details. I don't view it as like putting authorities at risk. I think it's just a budget neutrality exercise.
Thank you, Brian. I really appreciate that. I'm glad I'm not the only one who's confused about that piece.
Yeah, one thing I'd add, and Brian, I'd like to have you kind of give your, I met with CMS this week I was back east and was with CMS leadership. And I think broadly what we're seeing is a greater level of evaluation, and where there's areas of gray, they intend to address the gray areas and close loopholes or gaps that may have been previously exploited around policy areas, right? It's confusing when some states are operating policies that may be different than others because it's not clearly defined. And I think what we're seeing is that CMS and, per the new director, he is their team is going to be very focused on making sure some of the gray areas are addressed. And I think that's part of what Brian was describing, but I also think that is a more uniform approach we're going to see around our evaluations generally with CMS. And other states are certainly getting, experiencing some extended review times, and we ourselves are back and forth. Anyway, I would just state that is something that they were very clear about, that they would have more oversight and that they would be addressing the gray areas.
Thanks, Jen. I appreciate it.
Yep, you're welcome. Anything else? Okay, great. One other thing I thought we'd announce real quick. Brian, would you mind, the details on the medical respite RFP, would you just make that announcement to the MAC right now? We've talked about medical respite for some time, and this was a service that allows up to 60 days of a home health level of care. It also allows room and board for individuals who may be coming out of an inpatient facility who would otherwise be released to a situation of housing instability. And we have an RFP posted now, and I was hoping one of Brian's teams is going to be overseeing that. And it's wanted to just let you know about that quickly.
Yeah, thanks so much, Jennifer. Yeah, for specificity, the RFP is currently posted, accepting applications until May 23rd. So if you or someone you know is interested and qualified, you are certainly invited to make that application. The qualifying facilities are either assisted living facilities or federally qualified health centers that subcontract with a facility that can provide that residential medical respite services. And I think I'll work with Sharon to distribute the link to that RFP after this meeting concludes. But we are looking forward to it. As a reminder, the draft legislation or the legislation that came out last session allowed us to contract with up to 2 facilities. So once the RFP concludes, we will work towards trying to get a contract or 2 contracts in place.
Thank you, Brian. Okay, Dr. Britton, I'm going to pass it back to you. It's 5:30. So,
All right.
yeah, thank you.
Thank you so much for keeping us up to date on the evolving issues with the new Medicaid funding. We're eager to keep working with our representatives and senators to try to help them make wise choices. Last of all is committee member updates. Are there updates for committee members that they'd like to share? Okay, if not, then our next meeting will be Thursday, June 19th, back at our usual time at 2 p.m. And thank you all for the work you do to help support our Utahns on Medicaid. Thanks. Do we need to do a motion to close, or we just close?
You don't have to do a motion because we went through all of the agenda items. So you're good to wrap up.
All right. Thanks, team. Then take care.